Good morning, good afternoon, good evening, maybe for some of you, and welcome to another IPC Partners webinar. We're going to be talking today about invasive meningococcal disease, and I'm delighted that we've got Jon to be running us through an insight webinar. We've developed this off the back of the kind of ongoing situation that's currently going on in the UK, and I'm sure a lot of you on the call will be familiar with the current outbreak that is still ongoing in the Kent region of the UK. So yeah, we're going to run through that. Before we do delve into the webinar, we'll just remind people of what we're trying to do from an IPC partners perspective when we're talking about our insight webinars. So ultimately, we're trying to provide an expert overview on a relevant topic. And of course, the current outbreak of meningitis is very topical at the moment. Ultimately, though, we want it to be able to generate discussion. So we'd really love to hear your opinions and thoughts by using either the chat box, and then please use the Q&A at the top of your Teams bar for any questions you might have for Jon. This is CPD accredited as well, so there is one CPD point available for this webinar. And ultimately, we want it to be able to build confidence for independent research and study and try and have a little bit of fun as well. All our recordings or our webinars are recorded and made available after the event. So Jon, before we start, what's your current perspective on the outbreak at the moment? I think there were around about 40 cases in total when I last looked, but where do you think the
Yeah,
status is at the moment?
fewer than that. There's 20 odd, but we'll get to the detail. Well, UKHSA have told us that the outbreak is past its peak, so that's really good news. So I think it's a downhill trend from here in terms of case numbers. And then the learning can commence, really. We can kind of unpick what's gone on and how much of this has been driven by new strain emergence versus behaviors versus host and environmental factors, the usual kind of questions we have following a high profile outbreak. I think one of the most interesting aspects of this outbreak was early on, the rhetoric from UKHSA was quite bold. They was talking about unprecedented scale, rapid transmission, things that they don't often talk about. So I think there was a need for rapid public health awareness as part of this outbreak.
Yeah, really good overview. And you might go into this in the webinar, but in terms of like the rapid transmission, is that something that you think has been seen here, and is that down to the organism and the strain, or is that a new characteristic that we haven't seen before?
No, I don't think so, and I'll cover it when we go into the detail. But I think it was situational. I think there was a couple of events, a couple of incidents that resulted in pretty rapid transmission, and beyond that, Neisseria meningitidis as an organism has behaved as we would expect it to.
I've had to brush up on my spelling of that because that is a tongue tire to say it, but it's also a really difficult one to spell it with all the different I's. Okay,
Yeah.
just finally before Jon, I let you take us through. We've got well over 100 people online, so please use the Q&A. You can also use the upvote function if there's a question there that you'd really like Jon to try and answer. Jon's going to walk us through the slides in around about 20-25 minutes, and then we'll have plenty of time for Q&A at the end. So yeah, thank you all for joining, and Jon, over to you.
I told you not to tell them how long I was going to be because I have no idea. You've set
I
me up
put you
for a
on this.
fool now, Phil.
No, your time is perfect. Cheers, Jon.
Okay, thanks, Phil. So, and hi everyone. Thanks for joining today. Thanks for taking time out of your busy day. I hope that there'll be some usefulness. I consider myself a bit of a bacteriologist by trade. It's kind of the path I've taken through a laboratory to become a clinical scientist. So, I understand a little bit about bacteria, but Neisseria meningitidis is quite an unusual organism with some unusual characteristics. So I've done quite a lot of learning for this webinar, and I hope that I can share that with you. There's a chance that with a fast-moving situation, I could have got something wrong. So I'm not above being told I've got it wrong, and there will be, I'm sure, real Neisseria meningitidis experts on the call, and I look forward to hopefully a lively discussion afterwards. So what I've tried to do is give a sort of high-level overview, but maybe a little bit back to basics on Neisseria meningitidis in terms of its microbiology, its epidemiology, pathogenesis. Thinking about infection prevention, control and transmission, and also linking that to the current outbreak in the Kent region. So, the outbreak in Kent will fade away for sure. it's on a downward trend now, and it's not the first significant outbreak of Neisseria meningitidis, invasive meningococcal disease. Now that is a mouthful, in the UK, and it won't be the last. So these the information we talk about will hopefully be useful for your day job as well. And bearing in mind there is around one case of meningococcal invasive disease in the UK every day. So it does happen, and there is a background, but clearly what's happened in Kent is well above that background level. So you may have noticed there has been quite a significant amount of press coverage about this outbreak, and I think that's partially been driven by the public health need behind it. I should have said at the outset, I don't have any particular public health insight into this outbreak. I'm a director of IPC at a London hospital group, so I've seen some kind of the usual communications that go around, but so I don't have any, secret knowledge that I'm telling you today. I'm working on what is in the public domain. So the sense is, as I mentioned at the start, that at the beginning phase of this outbreak, there was a need for urgent communication of the need for people who've been potentially exposed to come forward and either be vaccinated or have the prophylaxis, depending on their type and exposure. However, quite a lot of the media and the press coverage has been pretty hopeless, as is often the case from a technical point of view. And I do think there's a risk that if you were to read some of the press around this outbreak, you might make two very erroneous conclusions. One is that Neisseria meningitidis is somehow meningitis, or that Neisseria meningitidis is somehow invasive meningococcal disease, and neither of those things could be further from the truth. Yes, Neisseria meningitidis can manifest clinically as meningitis, and yes, it can cause invasive meningococcal disease, but those states are very much the exception, and the norm is very much one of colonisation, and we'll come to that when we start thinking in more detail about the microbiology of this organism. So let's start with the current outbreak. So we were presented with a rapidly evolving, what turned out to be meningitis B outbreak centered in the Kent-Canterbury region. As of 5 minutes ago, when I checked the latest on the UKHSA website, there were 20 confirmed and one probable case in terms of the case definitions that are listed by UKHSA. And those were identified and reported between a 10-day period, which mainly affected University of Kent students, and sadly, tragically, 2 deaths have been reported. Several cases have been traced back to a shared exposure at Club Chemistry in Canterbury, and I've heard quite a lot of stories about an element of confusion around Club Chemistry and what it is, with some people assuming that it is a university educational club, but it's not that, it's a nightclub. And so that probably helps you to understand a little bit more about the potential transmission within that setting. And the outbreak emerged and was characterized, certainly initially, by unusual pace, with the early cases all turning up within a 48-hour period. From a microbiological point of view, we know we're dealing with a serogroup B or MenB Neisseria meningitidis clone, and that's been recently subtyped as a new emerging genetically distinct lineage. All indications suggest that it's susceptible to common antibiotics and covered by the MenB vaccines that are available. And before we move on and away from the current outbreak, just to give an idea of the public health actions, this is really a flavour rather than an attempt to be comprehensive in summarising the outbreak. But we know that informed letters have been sent to many students and staff. Antibiotic prophylaxis offered to students in the affected halls, staff in the affected residences, individuals attending Club Chemistry on the 2 key dates, and close contacts as defined by UKHSA. And anybody working in a acute healthcare setting in the UK will have probably worked through the documents to understand how we manage potential staff exposure as well. And as is as is right in this circumstance, UKHSA and NHS bodies have been collaborating and coordinating to provide clinics in order for delivery of vaccination and prophylaxis as required. So let's go back to the lab and the almost lost art of microscopy in a digital age. So what do we see with Neisseria meningitidis when we look down a microscope? Well, we will see a gram-negative Diplococcus, and you can see an image there. Quite confusingly, I think, the organism is sometimes called the Meningococcus. Now, if anybody can think of a good reason for doing that, do please let me know, because from my point of view, it's just confusing. And we should just stick to Neisseria meningitidis or N. meningitidis in terms of describing the organism involved. The primary state of this organism is as a nasopharyngeal colonizer. And as we'll see in a minute, somewhere in the region of 5 to 10% of the human population is colonized, and it's certainly higher in certain groups. And as I think is important to get across, colonization is the norm, and invasive disease is very much the exception with this organism. So if anybody's interested in doing a bit of learning after this event, I can highly recommend this Lancet Infectious Diseases systematic review and meta-analysis of Neisseria meningitidis colonization. And this rather beautiful, I think, chart shows you the observed data in the circles and the fitted data with a model. And you can see there the age variable prevalence of colonization. So it's sort of 5% in a newborn, rising up to something like 25–30% for adults, young adults at the age of 20, and then declining year by year over time. I think the sort of pathogenesis behind that age specific colonization profile is a science in itself. There's a huge volume of data, but my take is that much of that variation in colonization prevalence is environmental, in terms of it's the types of behaviors and activities, the social mixing that's happening in young adults that probably is the main cause for that increase in colonization in the young adults. But if anybody has other views on that, I'm all ears. So the microbiology of Neisseria meningitidis is governed by serogrouping. So there's a set of vaccine preventable serogroups, A, B, C, W, and Y. And the UK burden is dominated by MB, followed by C, Y, and W. Some serogroups are associated with colonization and others with invasive meningococcal disease, but it's not as simple as saying you've got MB, therefore you will get invasive disease. So these serogroups can turn up in either state, depending on a number of factors that we'll look at later. So for Neisseria meningitidis to cause invasive disease, and again, if I can just direct you to this excellent Nature review in microbiology, it's from 2009, so quite old now, but I think because of the type of data it's talking about around pathogenesis primarily, the principles are still as true today. So fundamentally, invasive disease results in a breach of the mucosal barriers, which leads to bloodstream infection or CSF, cerebrospinal fluid invasion. And the key virulence factors required for that transition are capsule expression, the ability to evade host immunity, and some strain-specific attributes that mean that some serogroups are more prone to cause infectious diseases, invasive meningococcal disease than others. So let's think about epidemiology. So of invasive meningococcal disease specifically. So the epidemiology of IMD has been affected quite radically by vaccination, and it's a real success of vaccination, which we'll look at in the next slide. So IMD remains rare, but severe, and despite modern treatment, including antibiotics as rapidly as possible when the diagnosis is made, case fatality is still around 10%. And that just illustrates how rapidly clinical progression occurs. As I said, there's around about 1 case per day of invasive meningococcal disease in England, and 31 deaths. So you can see roughly that 10% case fatality rate. And in the previous year, there were 340 cases, so around what we'd expect to see. Peak incidence tragically occurs in the very young and young adults, and that is reflected in the current outbreak demographics. And you can see that since 2018, there's been roughly a year-on-year reduction in the number of IMD cases that have occurred. And you can see in the bottom panel of that chart, that reduction has been most dramatic numerically in the less than 1 age group. So let's think about clinical presentation then. So we talked earlier, despite the name, which is in retrospect rather confusing, meningococcal invasive meningococcal disease presents as meningitis only around half of the time. Most of the other cases present as septicemia, so infection in the blood, and mixed presentations are common. Less common presentations are pneumonia, septic arthritis, and pericarditis. The disease is characterized by abrupt onset and rapid deterioration. And as we referenced earlier, mortality remains substantial despite treatment. And sadly, long-term sequelae are also common. So hearing loss, neurological deficits, and others can result. So people can be really affected for the rest of their lives by a brush with invasive meningococcal disease. So vaccination, routine coverage of MCA, CWY, so the 2 vaccines are achieved at adolescents. MenB was added in 2015 for infants, but it is noteworthy that immunity does wane. So most adults don't have the same protection as younger people. In this circumstance of the outbreak, UKHSA is recommending targeting MenB vaccination for some exposed individuals who don't quite qualify for prophylaxis. It's also true that some strains are not covered by current vaccines, so we need to be careful to manage symptomatically and seek early care. The impact of vaccination and the vaccination program has been pretty spectacular. So this chart shows you a slightly different view of the number of meningococcal invasive disease cases that occur in England. And you can see on the bottom panel when the vaccine was introduced. So the MCC vaccine introduced in the late 1990s, and you can see over the subsequent 3 or 4 years, the prevalence of Men-C has reduced from over 1,000 cases to a handful per year. And you can see similar trends occurring now with Men-W based on the introduction of that vaccine in 2015, and Men-B, we hope to see a similar decline as well. So the take home is that vaccination is really effective on a population level. For those who meet certain exposure criteria, first-line chemoprophylaxis is a single dose of ciprofloxacin, which is an antibiotic, with age-specific dosing, and that's recommended for close contacts and healthcare staff who've had some degree of PP breaches, which will be risk assessed. Moving on then to think about transmission. I mean, the short answer is you need to work pretty hard to transmit a Neisseria meningitidis. It's not an organism that spreads rapidly or easily, and it usually requires close and prolonged contact to initiate transmission. So that's often household exposure. Intimate kissing, intimate to differentiate from a quick peck on the cheek. Sharing of drinks or vapes, and crowded settings, as in the case in Kent, the nightclub. I've copied and pasted the relevant line from the National IPC manual for England so that we can just be clear on precautions in a healthcare setting. So you can see Neisseria meningitidis there, and the diseases listed: meningitis and septicemia. Droplet transmission-based precautions are being recommended, including a single ensuite room, a fluid repellent surgical mask for routine care with an FFP3 or hood for AGPs, and this is a notifiable disease, and it's important to note it's both a notifiable organism but also disease state, and we'll come on to that in a sec. So how do we put the transmissibility of Neisseria meningitidis into context? Well, one way of looking at that is the basic reproduction number. So that's the number of individuals that will be infected by another in a naive population, i.e. an unvaccinated population. So the R naught of Neisseria meningitidis, as always, is difficult to be accurate about and will depend on strain variation, but it's around 1.3. And if we compare that with the basic reproduction number of a range of viruses that we're familiar with, we can look at influenza of various types, ranges between sort of 1.75 and up to 4 for the Spanish flu. The king of transmission remains, or queen of transmission, is measles, with a basic reproduction number significantly higher than any other. So the point here is that the transmissibility of Neisseria meningitidis is really quite low relative to other organisms. That being said, we have a responsibility to prevent spread, and a key principle of doing that is rapid identification of the clinical symptoms and, of course, urgent antibiotics, and that will help to reduce, not only to take care of the patient, but also to reduce transmission risk. Public health notification is key. Coordination between IPC public health clinicians and laboratories is crucial from an IPC point of view, because if we're not talking to one another effectively, then transmission will occur that we're not aware of, and transmission can occur through the cracks in communication. So early isolation when patients present with symptoms consistent with bacterial meningitis are particularly important until meningococcal disease is excluded. So to try and sort of turn that into a bit of a checklist that may be helpful, and again, this isn't an attempt to be comprehensive, that there's guidance for us to look at, but just to give us an overview of the sorts of activities we should be engaging with. Prompt contact tracing, working hand in hand with UKHSA is really important as and when you have a case. Ensuring we have access to prophylaxis clinics for those who need it and helping them to understand it is crucial too. Internal briefing of our clinical teams with signs and symptoms and to maintain a heightened index of suspicion is crucial as well, because staff are busy, they have a lot of different priorities. So it's a case of how do we make sure that this is high enough on their agenda. Reinforcing good practice behaviours around saliva sharing, in affected populations, vaping, sharing drinks is crucial. And ensuring prompt notification of both meningitis as a disease and Neisseria meningitidis as an organism is also crucial. So typically this isn't something that a corporate IPC team would take care of. They'd be more involved in the preventing cross-transmission and the organisational preparedness. This needs to be owned and delivered by the frontline clinical teams. But if we get that aspect of it wrong, we might find ourselves in hot water, because one of the features of this current outbreak is that there was a delay in the initial notification of the meningitis case that then delayed the identification of the outbreak and the subsequent prevention measures. So finally, before I get to hear your questions, just a brief thought about research priorities. Focused on the current outbreak, very interested in the new clone and the variant that's emerged, and whether that is fundamental to the epidemic behavior in this scenario. My best guess is it's not going to be the case that this is an especially transmissible strain or clone. I suspect that the short-term success of this particular clone is situational rather than microbiological. And in general, assessing the role of crowding and behavior patterns in this kind of rapid microcluster type formation, and that's difficult to study because you don't know when it's going to happen. So we're piecing together historical records already. More broadly, what do we do with MenB vaccination? It's a new thing and it's being sort of rolled out. And meningitis vaccination more generally, or meningococcal vaccination more generally. Should this be a prompt for some further discussion about extending the program to different age groups or with different serogroup coverage? Genomic surveillance early will help us to keep a good track on this. I don't know whether it's true that all of the meningococcal invasive disease isolates are sequenced and subtyped, but perhaps that's happening already. If it's not, it should be. Looking at IPC effectiveness in social settings, there's not a great deal of literature out there, and strengthening our risk communication frameworks for rapid onset clusters will be crucial too. So with that, Phil, I will stop and look forward to hearing a few questions.
Cheers, John. Those are really good data presented there. I really like the R0 comparison and thinking about where it fits in with all those other organisms. It's just staggering how high measles is, isn't it?
Yeah, really, it is like the absolute gold standard in transmission.
The gold standard, yeah. Okay, so please use the Q&A box for any questions. It's just at the top of your screen there, right next to the chat box in your Teams barrier. Harry, so to delve straight in, John, Harry says, how's the MenB vaccine being used for gonorrhea? Protected some groups of students that are eligible for that vaccine through sexual health services?
It's a good question. I don't know the answer to that one, so I have to look that one up. Pass.
Okay, not very often that you stump, John.
Yeah.
So you talked a lot about kind of IPC guidance, and I think you gave a really good overview of, where that should be directed. But if you are working maybe in a social care setting or outside of acute healthcare, where would you push people towards getting their guidance from? Or are there any kind of key recommendations that you want to pick up on?
Yeah, I mean, this outbreak has very much fallen in those spaces, and whilst there have been a small number of cases involved in acute care, I think the majority of the workload and the public health and prevention activities have happened outside of acute care. So absolutely, the UKHSA guidance that's been published and circulated is the place to go, which is pretty definitive about the public health actions for sure. And actually, in my experience, the health protection teams are always incredibly willing to support.
Good advice. You've seen as a question about those who are affected. Do we know if they're all university students?
The guide no, the information that's available says the majority of patients are effectively university students. So we don't know the exact breakdown of that within the publicly available data, unless there's something I've missed. And that would be consistent with the mass transmission event in club chemistry.
Yeah, I also had that confusion over was club chemistry a homework club, or was it?
Yeah, well, I did too. When I first heard it's to do with the chemistry club, you think, oh, what were they doing? But yeah.
Yeah. And I think we kind of touched upon this at the beginning, John, but what's your perspective on, where the outbreak is now? You said we're over the worst, but do you think that's the end of it?
Yeah, I think it probably is for this outbreak. I don't think we're going to see a kind of second wind in transmission. I think the prophylaxis is out. If things were going to carry on as they are, I think they would have done so already. So yeah, I definitely think that the this outbreak is on the way down now.
Okay, great. There's a question from Claire here about vape sharing, and you referenced that in your presentation. Claire's asking you about how significant you think the impact or potential impact of vape sharing had on the transmission of the disease.
Well, I can feel a case control study coming on. So hopefully some clever public health scientists are out there right now interviewing lots of people about their use of vapes, about the sharing of drinks, around who they had particularly close contact with. And that's the kind of thing that would come out really nicely in a well-conducted case control study, which is what I was meaning by some of those applied research opportunities that we don't often get to study in these kind of short-term dynamic transmission scenarios. So I don't know what the answer is going to be about vapes or the relative importance of that versus other transmission routes. And I'm hoping that the case control studies will help us.
Yeah, definitely. I really liked what you did about, the call for research and where that needs to go as well. So it'd be really interesting to see what falls out of this. Claire also says that she's been working on a project using behaviour change models, framing hygiene and IPC as a tool for reducing vaping harms in children and young people. But unfortunately, there isn't much evidence out there.
Yeah, I mean, that's interesting to think about how we can take our practices around prevention and our learning about behavior change outside of acute care. I think that's a really fruitful area of collaboration research for sure.
Great. Okay, question on treatment, John. Mario says that in some other EU countries, we're not part of the UK, the EU anymore.
Yeah.
Rifampicin is first line. Is there any reason why ciprofloxacin is first line here?
Do you know, I didn't actually look at the data behind the choice of Cipro as frontline because it's such clear, definitive public health guidance in the UK. I wasn't aware that rifampicin is used as frontline in others. So I don't know the reason for that or the evidence base for it, except that usually UKHSA are pretty solid with their decision making around that kind of thing. So I think we can have quite a lot of trust in that recommendation.
Lots of hard questions here, John.
Yeah.
Yeah, another one here is asking about vaccination status of those who were affected. Do we have a feel for what percentage of people were vaccinated, if any?
Do you know, I haven't seen that in any of the
Mm.
information. So this was at MenB, and the vaccination program for MB only started in 2015. So logically, the answer is probably none of them, actually, thinking it through.
And do you think that some of the themes that we've seen carry on from COVID might have had an impact here? I mean, in terms of, anti-vax and vaccine fatigue?
Um, I think that's certainly true for meningitis and invasive meningococcal disease generally. And some data I didn't show today, but did pick up as I was going through preparing, was in the US, there seems to be a rebound in invasive meningococcal disease over the past 3 years since COVID. And that probably is to do with vaccine hesitancy or possibly some anti-vax movements. And actually, if you look at that in the context of the impact of a solid meningococcal vaccination program in the UK, it's a tragedy, really, that we're seeing an increase in a rebound in a developed country, presumably due to poor vaccine uptake.
Yeah, it's concerning, isn't it? And will we continue to be in this position with other organisms, I guess? Okay, there's actually a couple more questions, John. Are some people more likely to get IMD, good acronym, if exposed rather than just being a carrier?
Yeah, that's definitely true. And in fact, having carriage with a very low pathogenicity strain is the best protection against IMD, because IMD most commonly occurs shortly after the acquisition of a strain with the potential to cause invasive disease. So the exact triggers that cause that new acquisition to result in IMD is a bit more tricky to put your finger on because it involves that complex relationship between the microbe and the host and the environment. So those kind of three things combine to create the conductive environment for the new acquisition of the invasive strain to cause invasive disease. But it's certainly true that people who have established colonisation with a low pathogenicity strain are very unlikely to get IMD at all.
Okay, that was a question from Colette, by the way. Thank you, Colette. Barbara asks, any different or key learnings for future outbreaks such as measles? Barbara says about how universities target students meaningfully for IPC, and can they use learning from other initiatives such as climate change to tap into kind of the student drivers?
Well, never waste an outbreak, as the saying goes. And I think university students have other things on their mind. They're learning, they're socializing. Outbreaks of infectious disease are probably fairly low down on their priority list or worry list. I suppose in the case of invasive meningococcal disease specifically, that early detection of serious symptoms is probably the most important thing to take away, in that we want all university students to be aware. I mean, do they know that carriage of Neisseria meningitidis is higher in that group of people? Perhaps that's, I don't know, I'm not in public health messaging, Phil, but perhaps that's not a public health message that you want to get across. Maybe that risks fear and that drives the wrong behavior. But I do think that early detection of symptoms is a good message coming from this outbreak. Ensuring your vaccinations are complete and up to date is another.
Really good advice. Maybe final question, just because we've got a couple of slides to get through, is you talked about how it's quite hard to transmit the infection and you've got to work quite hard, and you gave some really good examples about possible mechanisms of transmission. Any evidence for environmental and kind of non-direct transfer or transmission?
No, I didn't see any, and I didn't look at survival in the environment because all the evidence points to prolonged close contact and respiratory droplets.
Great. Okay. Okay, Jon, huge thank you. And thanks to IPC partners for putting this on at such short notice. We're trying to respond to things that are, topical and in the news. So it's great to see so many people online. I failed to mention that we did this webinar in partnership with the Infection Prevention Society and the Healthcare Infection Society. So delighted to partner with them. So we've got a schedule of webinars. If you're new to the IPC Partners webinar and Journal Club, our next one, we're delighted to have the IPS Vice President, Kerry Holden, on, and Kerry will be talking about addressing healthcare inequalities in IPC. You can scan the QR code that will take you directly to the registration. That's our schedule there as well. So we're typically running on a frequency of a Journal Club and then an Insight webinar every 2 weeks. So you can see the schedule there, and you can also sign up and subscribe if you'd like to get updates. Jon, you're getting lots of applause emojis. I can see at the bottom of my screen. You can also rewatch as well. All this content is designed and delivered completely free of charge. So we'd love you to have the opportunity to be able to share this within your organisations and teams. It's a passion of Jon and I's to share education. So please do share our recordings on YouTube, and you can access all the recordings there. So finally, just a quick message from our partners. The IPS also have a really interesting schedule for events and conferences and study days. You can see all of the conferences, webinars, meetings there on their website by using that QR code. Just a quick note on special interest groups as well. There are various ones that are run both by IPS and HIS, but just to mention two here from HIS, Spark, which is a really new initiative. I actually checked out the website recently, and there's loads of really interesting work going on there, including recent academic studies and published work, which is great, and also building safer hospitals as well. I can't quite articulate the acronym BP. Also then some courses from HIS. So there's a water and wastewater safety and healthcare course, which you can register. It's over 3 days, held on the 12th and the 15th of May. And again, something that's really important and topical at the moment from an IPC perspective is water. So please do take a look at that. And of course, you can become a member of both HIS and IPS. You can join HIS for £90. And there are some discounts available as well. So please feel free to take out and have a look at what HIS membership brings you. I think that's our last slide, John. And yeah, just a huge thanks, John, and hopefully we'll see you all again soon.
Thanks, Phil. Thanks, everyone. Bye for now.
Take care. Bye.